Well, good morning, good afternoon, good evening, wherever you are in the world. I really hope you're well. I'm so pleased to welcome you to this webinar in which we're going to be having a little think about the kinds of things we've done ever so well in the last decade and how we're going to use that to inform what we're going to do ever so well in the future. So it's an absolute pleasure for me to be joined by two fantastic colleagues, Professor Janet Pope, who is in Western Ontario in beautiful Canada, enjoying the fall colours, I suspect, Janet. I was recently in that general corner of the world and the trees were looking pleasingly brown, gold and red. So lovely to have you drag yourself away from nature just for a few minutes, Janet, to share your wisdom. And Professor John Isaacs from Newcastle in the UK. I think you've got nice autumn colours down in Newcastle and Northumberland as well. Yeah, John is nodding accord, so that's great. And it's just terrific to have two really seasoned clinical investigators who also understand the underlying pathogenesis, the underlying methodologies that have created a literature that informs our current practice. So look, I know you're joining us, we know from the past series of webinars from all over the world. So I hope I've got my cup of tea here. Make sure you have yourself a cup of tea, cup of coffee, glass of water, and settle down and listen to what we have to say to you. As ever, there are a couple of housekeeping remarks for you. Please, you will remain on mute if you are here as an attendee. So if you want to ask us questions, and I really hope you will ask us questions, please put them in through the Q&A function that you'll find on the screen, the little button Q&A. Pop your question in there and we will be doing our very best to answer them. And the rules, you'll all know what they are. They're very simple. If they're really difficult questions, I'm going to ask Janet or John to answer them. If they're straightforward, then I'll more than happily field them myself. Now, just if you are like me, occasionally technically challenged, if you have any problems with the technical side of things, please use the chat box and our amazing backroom staff are sitting ready to solve whatever conundrum, whatever problems you may be experiencing. So this is what we're going to do. We're going to welcome you and introduce you. Now, this is us, I hope, warmly welcomed, and you know who's on the call. Then we're going to hear from Janet, who's going to talk a little bit about treatment strategies. You know, I often reflect when I'm thinking out loud about progress in the last couple of decades. We've tended to celebrate the new medicines, the biologic era, the small molecule era. But you know, when you actually look at the impact and outcomes, we've at least achieved as much benefit from thinking about how we treat people, the strategies of care, and no one better than Janet to take us through that element of that incredible revolution. Then I'm going to talk a little bit about so-called stratification of patients. Well, I'm at least going to think out loud about the concepts that might eventually lead to the stratification of patients. And as I'll point out, and this is a spoiler alert, we're not quite there yet. We will get there, but we aren't quite there yet. And then I'm going to turn to my very dear friend John, who's going to look into his crystal ball and tell us what the future might look like. And I'm looking forward to that as well. So we're going to crack on shortly. Remember, please, questions into the Q&A box. And we'd love to hear from you. It's always the most interesting part of a webinar, if truth be told. So with that, I'm going to hand the control of the electronic buzzer to Professor Janet Pope and welcome you, Janet, to talk about, amongst other things, treatment strategies and new targets. So Janet, over to you. Thank you so much.
Great. And thank you, Ian. You've in a good way stolen my thunder because I think we agree with the same thing, that maybe our toolbox being used more effectively could be as important, if not in some cases more important than some of the new innovation, although both have helped our patients a lot. So these are my disclosures. So I want to talk about a few things in the next 20 minutes or so. So some evidence over the last 2 decades that strategy-driven care in rheumatology for our 3 inflammatory arthritis IMIDs. that we have strategies that have improved care. Talk about some new targets very briefly, because we're going to hear about where we're at and where we're going in the next lectures. Some examples and some limitations that our strategies aren't individualized, and maybe AI isn't ready to help every one of our patients, and we don't have real-time biomarkers yet. So it is my opinion, I think held by the literature and by many others as well, that our strategies have made such a difference. So, and treat to target, to try to aim for deep and rapid and frankly sustained remission has made a difference for our patients. So that sustained remission, thinking of treating to persistence, and you're more persistent if you get drugs earlier with that window of opportunity and treatment before damage occurs, whereas in days gone by, axial SPA, then called ankylosing spondylitis, had to have radiographic changes by plain X-ray. So we've come a long way. We've also had concepts that when patients are really doing well for a sustained period of time, to consider possibly tapering. But if you stop drugs, funny enough, they stop working. So not to fully discontinue treatment in general. Combination therapies along the way, profiling patients, seropositive as a for instance, but we don't have too many biomarkers, but the same risks are the same for multiple drugs, as if, for instance, if you have high disease activity, female, poor healthcare literacy, or poverty, poor access to care, you're not going to do as well. So some of these are system markers and some are patient markers. We've also had more early detection. Why? Because guidelines. So in rheumatoid arthritis, they found that the newer guidelines, which are getting old now, but the newer guidelines, which have served us well, will have more sensitivity. Not always as much specificity, but more sensitivity, so we can pick up people early. And the same with this whole theory of non-radiographic axial SPA, which I think can be quite radiographic. It's just not plain X-rays, so MR, et cetera. Then early clinics have come up, early our rheumatoid arthritis clinics, but also aggressive or effective treatment of psoriasis to try to prevent psoriatic arthritis. And now even looking beyond biomarkers at prevention, RA at risk, lots of names where we call often, but not always ACPA positive or RF positive patients who have arthralgia, et cetera. RA at risk is a tricky one. So a couple concepts in general, irrespective of what guidelines tell us, in general, more treatment is better in early rheumatoid arthritis. So in almost all, not all, but almost all randomized controlled trials, I'm now talking highly active RA, often poor prognostic RA. So I'm not talking someone with 3 swollen and 4 tender joints, but high joint counts, seropositive and or high inflammatory marker, and or having already early plain X-ray joint damage. The CS-DMARD trials, combos do better than monotherapy. Now, there's a couple times that that's an exception. In earlier RA or methotrexate naive RA, a JAK plus methotrexate might be as good as a JAK alone, might be, and is certainly superior to a methotrexate. And same with an IL-6. An IL-6 plus methotrexate might be as good as or slightly better than an IL-6 alone, which is better than a methotrexate alone. But our guidelines don't go there. So just keep that in mind as I become slightly critical over time on what I'm going to tell you here. Then upfront BDMARDs in early RA is better than conventional treatment. So this is many different BDMARDs that were outshone combo methotrexate with prednisolone, and sometimes with triple therapy as well. We also have our guidelines that say that if your patient is not responding fully on EULAR guidelines to methotrexate treating to target with prednisolone or some form of glucocorticoids, then you change whether they have, the change now is whether they have poor prognostic factors or not. You move on to an advanced therapy, a BDMARD, a JAK, and obviously profiling for risk in any patient. So that makes sense to me, the moving on, but does the initial treatment make as much sense as I would like? So I would like to say, and I am an author, but I am not a high up author. I'm not senior, but I will still be critical of my own and others' work, is that I think our guidelines have failed us, that most people don't go into remission. 30% of early RA patients to 50% will go in remission with guideline-driven care. So I think we can do better. And I think that the main blockage of moving to more effective treatment is we didn't have the data, but we do now. CS-DMARDs in combo and or with an advanced therapy, and methotrexate will do better than methotrexate alone. The other problem that we have, even though we have a better toolbox, is our persistence is really poor. So methotrexate has better persistence than some of our other CSD-MARDs and frankly, some of our advanced therapies as well. But it is a downhill slope. So we need to be able to do better than that. And even every publication will show that in general, you lose 15% minimum to 25% of patients in year one, the same amount in year two, then at least 10 to 15% of those remaining year over year afterwards. And that's why when some people back in the day transition to a biosimilar, they might have been that 10% risk of losing ground no matter whether you change them or not. So we don't have a durable response in many of our patients. So what about treat to target strategies? So in rheumatoid arthritis, always treating to a target gives more people getting that target than if you don't treat to a target. That doesn't mean we get everyone in remission, but we can improve the chance of remission. And that incremental difference in trials of RA has gone less over time because everyone pretty much accepted as a rheumatologist that treating to a target made sense. So this was a systematic review of 82,000 patients within studies and showing, so it was a winner and a loser kind of thing, that treating to a target, more people did better. But look at, we're talking remission rates, that's not even a full remission of DOS, less than 2.6 or less than different values, sometimes depending on which study. 17% at 3 months were in remission, same at 6. And by 1 to 2 years, it was 1 in 5 to almost 1 in 4. So yeah, good news, but not good enough. So this is important. And the predictors of remission, men more than women, normal BMI more than high BMI, higher education, lower baseline DAS, less disability, so lower HAC, and no initial use of glucocorticoids because not every study would have it unless if it was a poor prognostic factor. So glucocorticoids in some studies mean the patient's worse off. You need those steroids to get them as equal as everybody else. Okay, so even with the exact same drug treating to a target, patients did better. So we published a long time ago an adalimumab study where people were randomized to adalimumab by usual care with active RA. The bottom line is if we were treating to a target, we got people better more quickly. And by the way, that was mostly intra-articular or intramuscular glucocorticoids. So that's something we found. What about psoriatic arthritis? There are certainly data. So treating to a target in early psoriatic arthritis recently presented was the Monitor UK study. So that is a study that was thinking along the lines of the TICOPA, where they had randomized patients to treat to target with step up and trying to get to a moderate disease activity, a minimal disease activity. So that's a tight outcome. And basically, once they were good for a long time, you could possibly back off as well. But at 1 year, 48 weeks, a third were on methotrexate monotherapy, 15% were on their second CSD-MARD, and 15% were on a BD-MARD. So treating to a target got more people better, and it usually cost us the time and energy to make a difference if they weren't at the target. And we all know that in primary care. The other way you can look at it is, what about comparing methotrexate to methotrexate plus leflunomide? So a sub-study here was saying, are 2 drugs, CSD-MARDs, better than 1? No darn surprise, yes, they are. However, again, guidelines often talk about sequential serial therapy and the CSD-MARDs adding or monotherapy, adding to methotrexate or leflunomide or monotherapy when you move on to advanced therapies. So 2 drugs might indeed be better than 1. And the SPEED trial, also recently presented at EULAR, is basically showing the same thing. If you step up, you have more failures than if you start with combination, or if you rapidly have 2 DMARDs and then go to a combination if you need. And it's basically an elevator approach. You can do a better delta if you start with adalimumab plus methotrexate, Then if you start with CS-DMARDs in combo and then step up quite quickly, that's protocol driven. Then if you go monotherapy, then adding when you're a failure. So I think my patients would all want to be in the group that does the best. Again, you don't get everyone in a PASTAS good score, but almost half with early TNF use, about a third if you're CS-DMARDs from the beginning. Step up, I'm sorry to say only 8% because you're losing that time and possibly losing the window of opportunity. Many of you on the call also remember the SEAM trial. The SEAM trial, in brief, was basically looking at early psoriatic arthritis, randomizing patients to our traditional methotrexate. Again, these are patients with highly active disease of psoriatic arthritis, or etanercept, or both. And interestingly, two drugs were not better than one if it was etanercept in the arm, but etanercept mono or etanercept plus methotrexate were certainly superior on all outcomes, quite quickly differentiating from methotrexate monotherapy. I'm sorry, but our guidelines have failed us. We can do better. We can follow our proven therapies. We don't need all these head-to-heads. I think we need to use the proof we already have. The other concept is treat to persistence, because all good things come to an end, it seems, particularly in RA, where patients fall off the curve every year of benefit, and we don't know why, and we'll hear about that in the other talks. But basically, if you treat to persistence, more people stay on the drug. It does take more micromanagement, but it actually surprisingly, maybe surprisingly, saves money, even though because you're trying to get the best out of a drug before moving on, but you're adding other things or you're micromanaging the patient. So it's like running an HbA1c as opposed to running a blood sugar. You're looking over time to get a composite idea of how a patient's doing. What about other things? Therapeutic drug monitoring. I can admit I don't do it, but I can also admit that the literature has shown both reactive patients not doing well, and I don't know why. In RA, I move on. In Crohn's, they say if you're on a monoclonal TNF, is it high anti-drug antibodies? Is it a low drug level? What do we do with that data? They'll modify the dose or move on depending on what they find. But even proactive therapeutic drug monitoring, which isn't even always the norm in IBD, has shown from the Nordrum trial, it has totally shown on a drug like infliximab, if you are proactively following levels in anti-drug antibodies, more people do better, but at higher costs, meaning the higher amounts of drug. But a person doing well will cost the system less over time than one who continues to fail or fails and drops off. And this is just showing because they stratified by all sorts of patients, including SPA, RA, PSA, and psoriasis, as well as IBD. They all did better numerically. What about treating to a target in axial SPA? So the first problem is we don't know what the target should be. So if you make a target that's too difficult to achieve, sometimes you won't have statistical significance, even though you might have numerical. So there have been different targets proposed. The ASTAS, BASDI with quality of life and a CRP, imaging targets, etc. But what this shows you, as well as a couple other studies, is that if you treat to a target, you will get more people in whatever your definition of remission in axial SPA is. As well, if you look at, and so you heard about a bit about Ticora, but Ticopsa, so this is the tight control of SPA trial. So the outcome measurement wasn't a validated one, but it kind of made sense to the investigators. And basically, you can see always more people in red are achieving that response, and red was the treating to a target group. The primary outcome just nudged away from a p-value that was significant, but the primary outcome had some things that might take longer to change, including some quality of life issues, even though, albeit, that's quite important. So treating to a target, even axial SPA, where we're not sure what the target should be, not that we know what it should be in any of our diseases of inflammatory arthritis, but treating to a target gets more people better. So that's important. So the issues with T2T and axial SPA are lack of evidence of the impact of aggressive management on X-ray outcomes, because we're not going to MRI a full spine every other visit or anything. We're very uncertain as to which target, and it's really difficult to ascertain clinically what might be active axial SPA versus mechanical pain damage, pain, etc. And sometimes our therapeutic options are limited where we can't dose flex as much as we'd like to in our options. So what about our targets over time? So here you can see in rheumatoid arthritis, here's what's happened. Lots of drugs. There are drugs that you forget are approved in RA because we frankly never use them, such as cyclosporin and mycophenolate. But it's good to know that we do have approvals in case if our patients are in extraordinary circumstances or say overlapping with lupus, etc. Lots of innovation going on, and biosimilars in almost every marketplace have allowed for the expansion of alternate treatments. So in other words, the expansion of advanced therapies. What about looking here, CAR T? I'm not going to say too much, but I think CAR T is very expensive and very interesting on what's happening scientifically. Won't be ready for most of our RA patients for prime time anytime soon, but you'll hear more about that. The bispecific T cell engagers have shown that in difficult to treat RA, that they have improved joint counts, and they have also improved patient-reported outcomes, inflammatory markers, and synovial biopsies. Ready for prime time? Not yet, but there are trials going on. What about other things that might be occurring? Everybody's quite aware of GLP-1 helping things like psoriasis in high BMI patients, helping OA in high BMI patients, possibly helping psoriatic arthritis again in high BMI or maybe even normal BMI. So there's some thought that they can be anti-inflammatory in RA. And I don't know if that's beyond what happens at the fat cells or if it's you could have a normal BMI and get response. We don't know that yet. PD-1 agonist, we have to remember the first anti-checkpoint inhibitor that came before checkpoints was abatacept. And so anti-abatacept is a checkpoint inhibitor. Abatacept does not increase cancer in general. And PD-1 agonist would be anti-checkpoint and not ready for prime time, but a few trials still in phase 3 going on to maybe help our patients later. Also, the gut joint axis is a big deal in axial SpA and PSA, but RA as well. And in mice who are transgenic that will have inflammatory arthritis conditions that could mimic some of our diseases, you can certainly see TNF signaling goes up in their paw joints or wherever you're looking. Also, vagal nerve stimulation was approved in the US as something for difficult to treat patients with a slow but ongoing improvement over many months and a sustained improvement by 3 to 5 years on a significant amount of patients. So something more that we will learn more about, I think, over time. Then looking difficult to treat, I think there's a problem. There's a difficulty in difficult to treat patients with RA because all these people could have difficult to treat RA, someone who is reluctant to take anything, someone on chronic high-dose prednisone that helps as an analgesic effect, someone who hasn't tolerated anything, and someone who has serially had a primary or a secondary loss of effect, never had a sustained remission or very few sustained remissions who have tried most drugs. So there's different categories. So I don't think that this is the easiest way of classifying patients. So something new is looking at polyrefractory RA. RA that's difficult to treat, 1 in 5 of your patients. Polyrefractory, less than 5% of your patients, meaning they've basically tried something at optimal doses in pretty much every class of advanced therapy and a bunch of CSD-MARDs as well. I'm not going to talk much because I won't steal thunder, but we can do better by maybe looking at synovial phenotypes. We don't know how patchy they are. We don't know how they change over time. And sometimes we also don't know how to treat them anyway. But if you're a fibrotic pattern, you're not going to do well. What about the targets in PSA? A lot has happened. Our CSD-MARDs, our advanced therapies, and now there's even talk about nanoparticles and other ways of carrying antibodies that can last for 3 to 6 months, such as an IL-17 carrier platform and maybe CAR T. What about our guidelines in PSA? I think, again, we need to up front end load because trials have shown us people do better, at least in the short term. So the guidelines are good, but they are a guideline. But I think sometimes in some patients we can do better. GRAPPA also has very sensible guidelines that are through whatever strategy, lots of nail involvement, lots of entheses, etc. Then if we move on to Axial SPA, I wanted to highlight the Canadian guidelines that after an NSAID, these are similar to other guidelines, but after an NSAID, TNF, IL-17 or JAK, and it depends on the patient preference, the unique features of the patient, and extra axial and extra articular manifestations such as severe uveitis, IBD, etc. So in conclusion, I think without even going over time, which the chair will like, that both new drugs absolutely have made me a better doctor, and the strategies have made me a better doctor. I have learned to use methotrexate and CSD-MARDs more effectively because of strategies. And thanks to all these trials that have helped us in the strategies. And we have most patients, so here's the downside, that's the upside, the Pollyanna side. The downside is most patients are not in remission most of the time, and sustained remission over a few years in any of your practice of axial SPA, PSA, RA is not the majority of your patients. So we need to hear what the next speakers will say because this is so important.
Thank you so much, Janet. That was fabulous. You've covered a lot of ground for us there, which has given us such a lot of food for thought. Um, I'm intrigued. Actually, there are so many elements that I'd love to pick up. Quick question: do you think the treat to target strategy has been as demonstrably useful outside rheumatoid as it has been in rheumatoid arthritis? What's your sense? Because you cited Tycopa, you took observational data, which is not really randomizing and testing the strategy, monitor speed. I, your thoughts?
Right. So first of all, it was entrenched, and there's more RCTs that show the delta DAS as a for instance in RA. So absolutely in RA. But I think the strategy started in a positive way, metastasizing, spreading to our practice where we weren't going to accept multiple swollen joints, whether we agreed on a target or not. So I would say in psoriatic arthritis, there's a lot of strategies that would look up minimal disease activity, which is 5 out of 7. And it's a very tight target. And obviously, we'd love 7 out of 7 if possible. And axial SPA, I think it is a different story because it is very difficult to know what's going on. It's kind of akin to Crohn's, where they have to scope someone and look both macroscopically and microscopically to say someone's in Crohn's IBD remission, right? Fecal count normal, scope normal, and pathology on that scope biopsies normal. In axial SPA, it's not feasible right now without a proper biomarker, other than, I guess, a CRP where appropriate. It's not feasible to image a person repeatedly in a timely fashion. And I think that's where axial SPA has, it's been detrimental to us knowing the target and knowing, in whom is their active disease on any day. So that would be my sense. Is that what you would think, Ian?
Sort of. In rheumatoid, I think the evidence is unequivocal. You've reviewed it beautifully, and also we get reduction in comorbid risk as well. So I think Tycopa is a beautiful study, but remember the tight control site had 3 times the number of serious adverse events, and we've just not
And
seen
more
that.
biological
Yeah,
penetration,
and
and the differences by 5 years were kind of noise
absolutely,
happens. Yes.
absolutely. So it's a beautiful study, but it hasn't been reproduced. It's not been not reproduced either. We just haven't got enough of an evidence. And I was a little concerned that the Tyco SPA was kind of, it failed to meet its primary, but even in the paper, they kind of said, well, it didn't make the primary, but actually we should be doing this anyway. And that, I think and I got a lot of sympathy with the authors still, because it's just such a difficult disease, but in the absence of a good biomarker. John, what do you think? Am I being curmudgeonly? I often am, you know that.
No, I'm with you, Ian, actually. But I do think it's the amount of evidence rather than the fact that it's positive or negative. We're probably 10 years ahead in RA, if not a little bit more. So that's part of it. But I agree, I haven't seen a lot of convincing treat to target data outside rheumatoid.
And just no, John. So we like it. We probably like it across a range of diseases. I personal view of PSA should be each tissue should be judged on its own merit. when you start to escalate therapy against an actual tissue evaluation of disease activity, it makes much more sense actually than against a composite. We can maybe talk about that later. One final thing, what is treat to persistence? That concept, I'm afraid I didn't understand, Janet. So what does that mean?
Right, right. So instead of having 25% on year one and another 25% of those remaining on year two fall off the curve with advanced therapies, any of them with the advanced therapies, the treat to persistence idea is that if you can continue your person on the current medications by, in many ways, micromanaging, updosing if you can, adding a background CSD-MARD, or frankly, treating a flare, because not all flares are a new persistent disease state. Some are transient. So then you're not going to lose as many people falling off the drug. But the converse is, so here's the skewed part of it, is that if I have a person on the same drug for 10 years, well, let's not even go 10, for 5 years, they're probably a deep, rapid responder that has a higher chance of persistence. So they're different patients than someone who cycles every year out of the next treatment because they never got a deep, rapid response, or because they the drug levels aren't high enough. That's not, the disease isn't driven by something. So it's a self-fulfilling prophecy that people who do well persist, at least predictive value for the next 2 years. We don't predict well after that in RA even.
No, thank you for that. Yeah, fascinating concept. And as ever, really, really difficult to trial. Look, let's crack on. The next speaker is me, unfortunately. So Janet and John get to have another cup of tea, I guess. And for those of you listening to the webinar, I hope you're enjoying that. My brain is buzzing with all the questions I'd love to ask Janet. But let me take you into what we started to think about, which is this idea of stratification. And I think in truth, Janet was arguing for the strategy having thus far been beneficial. How do we take it forward? And obviously one of the ways we could take it forward would be by strategizing that this patient is the one who's going to get this intervention. Probably we're a bit ahead of ourselves. I certainly am, because I should just tell you that these are my disclosures. And as ever, this is beautiful Glasgow. Right. So this is one of my, at the moment, favorite quotes. I have a favorite different quote every week, to be honest, but this one appealed to me because I think all of us who are at the more experienced end of the clinical spectrum, which is just a diplomatic way of saying older, I think we're probably familiar with the idea that we've made along the way decisions that, with the benefit of retrospect, were not the best. And so what we're trying to do is to take Mark Twain's idea of making good decisions more often, and ideally doing so without the bad decision phase. That would be quite nice if we could do that. So this is just a quick resume to make sure that what I'm saying overlaps nicely with what Janet has just said. We've had this extraordinary era of therapeutic discoveries all the way through to small molecule inhibitors, which are quite therapeutically targeted. That in turn has led to a revolution right across a whole range of immune-mediated diseases. And of course, this has been, on the one hand, an unparalleled success. But I don't know about you, but when I have more than one option in life, I can procrastinate for hours as to which choice I'm going to make. And I think the problem we've got at the moment is we now have an embarrassment of riches. We've actually got quite a lot of good medicines. And just to pick up what Janet just said, if we do get the right medicine into a patient and they are that rapid deep responder, they tend to stay there. It's just not very many patients get there. And if we could just get that early correct decision making, look at the range of small molecules, big molecules, membrane targeting, soluble targeting, and we've heard a little bit about potential for CAR Ts and maybe surrogates for CAR T and vivo CAR Ts and all the rest of it. We'll come to that again later on. So we're spoiled for choice, and yet our target selection is a dark art. It would be quite nice if we knew whether a biomarker could predict a clinical response. It would be quite nice if that biomarker actually told us about the point in the tissue that's going to have to collapse. You know, think the airline industry. If Heathrow has half a centimetre of rain, most of Northern Europe's air traffic slows everything down. So there are certain points in the network that are exquisitely sensitive to blockade and can bring the whole system crashing down. But of course, the same is true of Schiphol. And that means in any one system, there may be more than one critical regulatory node, and that's probably the case in rheumatoid if you talk to the systems biologists. Ideally, we would like these to be pathogenesis based, and ideally we'd like them to be cheap and easy to perform and quick. So here's the problem. It is a dark art. Now, this is Scotland. This is a story I've told quite a long time ago. If you go to the tourist guides and you take a simplistic view of decision making, I'm going to visit Scotland for my holidays, you may be misled into going to the city with the great big castle. But that's a very superficial view of the world, isn't it? If you really understood you wanted to be in a city with 3 professional orchestras, professional ballet, with beautiful architecture from Georgian, Victorian, Edwardian times, with some of the friendliest people on earth, of course, you wouldn't go to Edinburgh, would you? You'd come to Glasgow. So a more detailed understanding of the performance of the very nature of a decision-making point will often lead to surprising decision, particularly if you've already planned your Christmas holidays in Edinburgh, but there we go. Now, we have to start to think about the challenges that we face when we simply apply the recommendations. And I wanted to further affirm Janet's remark that recommendations are great, but they don't replace the art of medicine. By following recommendations, outcomes are improved. But by religiously following recommendations to the extent of any other thought process, unfortunately, a lot of the value begins to diminish. So the art of medicine is the art of making decisions, clinical decisions, which can broadly be divided into 3 potential areas. First of all, there are considerations about the patient you're treating. So you've got someone in the clinic, you'll automatically as a clinician start to think, well, what age are they? What other problems have they got? If they've got bronchiectasis, I might think differently from if they have normal lung function. If they're obese, I might think differently for them to have a normal body mass index. Unfortunately, in the real world, we'll be thinking about their ability to pay. What is a payer going to say? Are they insured? Are they not? And so on and so forth. And then there's our own experience, back to Mark Twain, the physician's experience. And here we're starting to think about levels of training, levels of experience. Do you run a dedicated clinic? How many people run an RA clinic, a PSA clinic? Or are you just seeing all comers in a really busy, overloaded clinic? And these things matter. They really do matter. And so our clinical decision making, the art of this is impacted by so many variables. Interestingly, and I would argue probably not often enough, our decisions are rarely influenced by biologic evidence beyond a few simple biomarkers. So let's try and put a little more flesh in the bone here. So here are, I think, at least the de minimis list of comorbidities that you should have in your mind when you're making a decision about a given medicine A versus B. And honestly, I think these apply right across the board in the immune-mediated inflammatory disease space. So you should be thinking about different tissue domains, vascular system, brain, depression. What are the causes of pain? Is this nociplastic? Is this some kind of sensitization syndrome? Or is this a straightforward articular pain through the dorsal root ganglion to the brain saying, you know, I've got a great big swollen joint here, no wonder you're sore. And we have to think about those different domains of pain rather than just simply reaching for the escalation of dose or the change of MOA of an immune modifying therapy. We will be influenced by present or previous history of malignancy, infection. We'll probably be influenced by previous hepatic, renal, or respiratory disorders. So this is a very clinical model of the universe. We do use some biology, and I'm highlighting here rheumatoid and PSA. You could I think, construct very similar models for lupus, some of the more common connective tissue disorders. We use autoantibodies, we use CRP and or ESR. And in psoriatic arthritis, it's actually a little bit more difficult because in general, routine standard of care, CRP and ESR are much less useful in PSA than they are in the management of rheumatoid. People can have bona fide psoriatic inflammatory disease without much of an acute phase response going on. Don't know that I understand why that is, although on reflection, IL-6 receptor inhibitors weren't that effective in psoriatic arthritis either. So maybe this is telling us something about the way the acute phase response is working in PSA. So yeah, we do use a little biology, but we don't use very much. And I guess the challenge we'd be looking for would be to use a bit more. However, we use imaging. Most of us will employ ultrasound or MRI in our practice. And back in the olden days in countries like Scotland, we even examine people. Yeah, Janet examined peoples in Canada. I happen to know that's true because she's told me many times. And I'm certain that John examines people in Newcastle. And I would actually urge you to examine your patient. It's wonderful. It's also, you remember that, the art of medicine, the bonding that takes place when we meet our patient, when we shake their hand, when we gently palpate joints to assess tenderness and swelling. It's enormously reassuring actually for a patient. Lessons I think many of us could remember again. So we'd like to stratify somehow, and at least what we'd like to do is to have biomarkers that would help us. And you could imagine at the moment, we do use biomarkers, CRP, autoantibodies, either positive or absence of in terms of diagnosis. And that in turn leads to eventually a trial and error approach to use of drugs. We start with methotrexate. We have non-responders to methotrexate. There's a really simple decision point. Wouldn't it be lovely, given the data Janet's just shown you, wouldn't it be lovely to bypass the must-have methotrexate stage? And I think there's lots of clinicians out there who probably feel that that would be a smart thing to do. Now, if we look at the right-hand side of this image, the future would be that there was a clinical phenotype identified. So we'll still examine the patient. We're still going to have that conversation, but there will be some biomarkers that will assist us in allocating the right drug at the right time for that individual, or at least for a group of individuals who share that common phenotype. I'm not actually so zealous as to require a fully individualized discussion. I think I'm quite comfortable if we categorize people at least a sufficient level as to give a given threshold of response. And I don't know what that is, but if I could, even as a starting point, offer 50% patients in remission at 6 months, I'd be quite happy with that. And, we can actually do that with some of our medicines if you get the right medicine on board at the beginning. But it's not easy, is it? We've been doing this forever, and it's really turning out to be a challenge. Our diseases are probably physiologically, pathophysiologically heterogeneous. And quite a lot of our diseases are difficult to get at. You don't desperately want to be doing recurrent synovial biopsies, renal biopsies. We can't do brain biopsies. And so we're looking for surrogates. We're looking for the so-called liquid biopsy that informs those gold standard tissue evaluations. And I've already emphasized not only the presence of comorbidity, but please reflect those comorbidities are also bioactive. Adipose tissue is pro-inflammatory in the obese state. So this is not some benign coincident condition. It's an inflammatory and metabolic insult that will directly interact with the pathogenesis, with the likelihood of therapeutic response, therefore. And there's legion data now. Janet showed North Star data earlier on. Note that the presence or absence of body mass index elevation was a huge impact on the likelihood of responding across the board, regardless of MOA in that study. So, in fact, it wasn't quite the same as the magnitude of effect of drug against from time 0 through 6 months, but it was almost as big an effect, which is really quite sobering. So, lots of challenges. What are we going to do about it? Well, I'm calling this the evidence to aspiration gap. And some of you are very familiar with this famous rheumatologic investigator. This is Rheumadog himself. This is Toby the Black Lab, posing in the hills not far away from our home just outside Glasgow. Now, I highlight Toby because he's been my thinking companion on many a morning run. And he approves of the evidence to aspiration gap. I don't know if you will, but let me run it by you. The notion here is that we have lots of evidence for the current management of active disease. We have less, but at least some compelling evidence as to what is happening in remission. But we have very, very little evidence of the biologic events that must be overcome to achieve a cure. And cure here is drug-free with the reinstatement of immunologic homeostasis. I actually think drug-maintained remission is still a pretty fine target for us. And if we could achieve that in a large number of patients, our discipline would be doing very well indeed. So that's the gap we've got to overcome. Let me very quickly take you through these aspirations just to qualify them a bit more. Can we individualize these guidelines and recommendations? And at the moment, the answer is no. So we've got to work out how to do that. And we'll do that by generating effective biomarkers, be they synovial, be they blood-borne reflecting synovium, or be they a combination of cardiovascular, synovial, circulating blood, brain. I think this is one of the areas where biomarker biology has to move forward. They may have to become quite composite, in fact, to report disease in different tissues. And when they report that disease, they're going to have to overcome the second aspiration, which is separating those pathways in a tissue that are telling you about the disease from the generality of pathways that are active in a tissue, which I'm calling here immunological chaos. And this is something that we've been thinking a lot about. And if you're interested in reading about this, Clément Traillet put this very nice viewpoint together in the Annals just a few months ago. And it depicts the notion that at least one way of providing greater precision, greater stratification of patients would be to take the noise out, noise cancelling of all of the different immunologic events that we find in the synovium, allowing us to drill down on that which matters. And the area of spatial biology, I think, will take us very quickly in that direction. The next thing, and I've alluded to this already, but I think we need to explicitly ask what's going on in each tissue. I've somewhat lightly called this treat to tissue target, T2T squared. And the idea here is that when you have a patient with different tissues involved, you would think about those tissues logically and in sequence. And in our arthritis clinics, for example, in Glasgow, our fellows are very used to thinking skin, enthesis, joint, and every patient has their blood pressure measured, their weight measured. And we just go round all of the different tissues in the patients and evaluate where we're at in any one given moment in time. And quite often different tissues fluctuate given a medicine or given a state or time. The next aspiration, I think, is very much more difficult. But if we ignore it, we're going to be doomed to failure. The fourth aspiration is to think about how does our exposome, how does our life, how does the exposure we've had in the world change the way in which we present to our clinicians? Basically, our childhood, our teenage years, our early adulthood is not a benign influence necessarily, but we very rarely take it on board. Very, very rarely take it on board when we're trying to resolve and understand all of these elements. And finally, when does an immune disease start? This is a beautiful photograph of lakes in New Zealand. And you can just imagine what would happen if I threw a great big handful of pebbles into that beautiful still water. I would have no idea which pebble started, which ripple was the beginning, and which ripple was the next piece. And so we don't even know when the starting gun goes, and yet we expect that the extraordinary power of molecular medicine, along with the black box, which of course is AI, that just applying this will resolve all of the problems. Well, I beg to differ. I think it's probably going to be a bit more difficult than that. Janet alluded to what is probably for me the best show in town at the moment, which is detailed analysis of synovium. And here's the work of Professor Lewis and colleagues down in London, but it's representative, I think, of groups in different parts of the world, defining pathotypes, so-called different synovial predictive models. The problem is, do they last forever? Are they constant? Janet made the point. Are they transient, or are they truly long-term predictive? And there's some evidence that at least for some patients, they are quite predictive. And this is an example from that series of studies led by Cospitsalis. Pugliarese's study was able to show at least an enrichment at the transcriptomic level of response when one uses a B-cell targeting agent in patients in which a B-cell enriched response is present in synovium. Now, these have been really difficult studies to understand and interpret, but I really commend them to you, because they've been a heroic amount of work, and they are the beginning of a revolution, and we just need to keep watching this space. And then, as I say, this idea of treat to tissue target, proposition 2 for you is that we're going to have to stratify across many different tissues. And I would urge you now, when you're seeing your patients with immune disease, to think not only about the joints, think about the skin, think about the brain. Is this depression? Is this nociplastic pain? Is it prime articular pain? What's going on in the GI tract? What's the cardiometabolic status? If you're not thinking about all of these things, then the chance of long-term remission is low. And unfortunately, it's common. More than 50% of patients with rheumatoid arthritis over the age of 60 are, by definition, multimorbid, 2 or more coincident long-term conditions. Doesn't matter what the conditions are, you will do less well if you have 2 long-term conditions. And if you've got depression and rheumatoid, obesity and rheumatoid, you see how quickly these things stack up. So this is relevant to your practice tomorrow. And I want to highlight in particular the challenge posed by adiposity. We've been thinking a lot about this, and I commend you this article from Navid Sattar that we wrote just a few weeks ago in the Annals, in which we've highlighted that not only is an obesogenic environment and the presence of adiposity a risk factor, but it is almost certainly pathogenetically related to the way in which our patients progress and in which our diseases work. And finally, I want to introduce you to the concept of the brain-joint axis. So this is Neil Basu, who I'm really privileged to have working with me as a colleague in Glasgow. And Neil and his team have started to unravel ideas as to whether the brain is a separate, innocent bystander. It actually is not. The brain is disordered, dysregulated in people with immune diseases. There are changes in the way different nuclei connect one with the other. There is neuroplastic alteration, which has a pretty fundamental impact on the way in which our patients behave. And if we treat only inflammation and ignore the disordered neuroplastic neuroconnectivity, it's unlikely that our patients will be satisfied with that which we call remission. You know, the joints can be completely quiet, but if the patient's not happy, have we really done our job? And I think this is a way in which we can start to explain that. And the third proposition, I guess, is that pathogenesis-led discovery should be the norm. I think it's really not the trial and error approach that has been the hallmark of many years of drug discovery. There's been rationalization, but we've got to do this now with AI-driven rational pathway discovery right across the immune disease states. And that in turn leads me to my conclusion. We're not ready for prime time. Janet said that several times, and I'm just going to echo that. But this is Lord Kelvin. We just celebrated his 200th anniversary, famous Glasgow scientist, he of absolute zero. Imagine somebody in Glasgow thinking of absolute zero low temperatures. I can't imagine what he was thinking about. Anyway, we're amateurs compared to Toronto, Ontario, I think, Janet, if I'm not mistaken. Anyway, if you can't measure it, you cannot improve it. So we're not ready to measure with the biomarkers that we so desperately need, but I think we're getting closer. Thank you very much indeed. So I'm just going to throw myself at the mercy of John and Janet. If there's anything I've said that you violently disagree with, I'd love to hear about it. That would be great.
Ian, I've got a question for you, or a proposal. So one of the oldest biomarkers we have are autoantibodies in rheumatoid. And I increasingly dislike using, but I don't think I even use the term seronegative rheumatoid arthritis anymore. I find some other terms to describe my patients. And I just wondered whether yourself and Janet feel the same. But my refractory disease, although we're taught that seronegative disease is a better disease to have, and for sure it doesn't erode. But if I look at my really refractory patients, what did Janet call it? The ones that really don't respond, they're seronegative largely. So
yeah, they are.
I'd just be interested.
Yeah, I mean, the current guesstimate is they represent somewhere in the order of 2 to 3, maybe 2 to 4% of patients. So there's a lot of difficult to treat disease that is not polyrefractory, true physiological, pathophysiological bone fracture. Yeah, listen, I think we should simply stop calling the concept seronegative rheumatoid arthritis has no meaning to me in 2025. It's a non-phrase. It's misleading, and I think we should go to a stage where we talk about an inflammatory arthritis of as yet unknown classification or cause, and we just that sets up the challenge that we've got to explain these diseases far better. Janet, have I been overly ridiculously revolutionary there?
No, I think it was appropriately revolutionary. And just to chime in on this whole thing of seronegative RA, I guess should we be doing routinely on negative RF patients? Because that is now over a third of our early RA patients. And any of these contemporary cohorts, double positive, single positive, are still at not 3/4 of patients anymore. It's more like 2/3, maybe 70% if we push it a bit. So what are we classifying for the other 30%? Should I be doing anti-SON, 3,3-eta, and everything else? Or should I say, this person has a pattern that I believe to be RA, but I don't know what they have? And maybe we'd have to shorten what we've all just said, because I think the problem is once we call them seronegative RA, we forget to think. And I don't know how many are misclassified. And let's be honest, most of our drugs were tested in days where 3/4 or more of the patients were seropositive. And in
Yep.
long-standing patients, the median RF was higher than what's happening in our new RA patients on average, not within an individual. So I think we have to suss out what's going on. And when people don't respond to drugs, we like to blame them as opposed to our misdiagnosis and our the fact that we just have our blinders on. That being said and done, though, I think many of the other things you've said now, Ian, is that my patients when I first started weren't as comorbid, probably because comorbidities weren't diagnosed as much. So they probably were, but people got RA earlier, years ago, 10 to 15 years earlier than now. 25 years ago. So they got the age of onset earlier. And sadly, some of them indeed died of their RA. So they didn't live as long. They died of infections, malignancy, and cardiovascular outcomes as the main causes. Now, cancer is a chronic disease for many of our patients if they have comorbid cancer. They're often on polypharmacy, and polypharmacy, not just comorbidities. Probably if I give you 12 different tablets to take and 2 injections, or, what's the chance of 100% adherence? Certainly not anywhere near a high level. It's somewhat better than you would expect in some patients, but it's very difficult. So I think these problems are intertwined, and our patients have changed. And we say, there's less corneal melts, absolutely, but I still have patients with erosive disease. I still have patients with nodules. I still have patients that I can't turn off, even though it's not the majority of patients. But even my
So,
well-controlled patients stop being controlled over time.
so I think so. It's a cogent plea for at least defining seropositive disease and keeping our focus there. But when we have patients who don't have seropositive bona fide disease, keeping an open mind as to what they might really have. John, I'm going to use that as a cue to bring you in and ask you to think a little bit about the future. And then we will have a few minutes at the end of our webinar to take a couple of questions. Thank you for the questions already submitted. Please do pop your questions onto the Q&A box. We'd love to hear from you. John, I'm going to ask you to lead us into the final part of our webinar. Thank you so much.
Thank you. Thank you, Ian. And thank you for the invitation to contribute. Do I have control of the slides? No, I think. No, I'm not moving them on.
If you just keep pressing randomly, John, I found that generally works.
There we go. You're right.
There you go. You see,
There's my disclosures. That's my title. So what does a pathway-driven future look like? And again, thank you for the invitation. My talk's broken into 4 little bits, really, and they are relatively short. I'm going to talk a little bit about the therapeutic ceiling and not really recap a different view from perhaps what you've already heard tonight. I want to talk a little bit about reset and retune, and what these reset you've heard of. Retune's a term that I've kind of used for quite a few years, to be honest. slide or two on very early treatment. And at the end, there's a slide on biosimilars and generics, but it's more a discussion slide, really. I think that will lead into discussion rather than me presenting any data. So let's think about breaking through the ceiling. So I would argue there's a few ways you might, if you're thinking about how can we do better, there's a few things you might think about. So are there targets that we've missed? And actually, for this first bullet, I would say, are there novel inflammatory targets? My gut feeling is there's not, and I'll come back to that later on. But I'm not sure we're going to find IL-47 is suddenly the cure for rheumatoid. We've got a lot of good drugs against inflammatory targets. I'll come back to the immune bit later on, actually. That's slightly different. Are there new signaling pathways? Well, there might be. We've had a lot of success with JAK inhibitors, but I think what you've got to remember, there were lots of signaling pathways tested before that failed, and a few subsequently. So BTK inhibition hasn't really hit the target in rheumatic disease. Maybe some quasi-positive data in Sjögren's syndrome, but definitely not in rheumatoid. So again, I doubt we're going to really hit on a signaling pathway that gets us above our conventional outcomes. Again, I'm going to come back to immune checkpoints with immune targets in a short while. There's just other modalities. There's a few drugs coming along which are manipulating gene expression, but actually they're manipulating the genes that we all know about already. So unless they come up with a brand new, I don't think manipulating gene expression per se is going to be a magic treatment for rheumatoid, unless it happens to be a gene which we haven't tested in some other way. You've heard a little bit about vagal nerve stimulation, and that pops up quite a lot in searches of refractory disease and such like. I'm not sure we completely understand how it works, and I'm not quite sure where it fits in terms of immune and inflammatory targets, but I put it in there. Patients like it, of course, because it doesn't involve popping tablets or injecting themselves. So it's one to just have there. And then I also hear a lot of people talking about combinations these days. You know, for example, they say, well, JAKs don't inhibit TNF pathways, so surely there's a rational combination there of adding a JAK inhibitor to an anti-TNF. I confess I've tried that on a couple of patients, and actually I was very cautious. Maybe I was too cautious, but it didn't really help. And I think, although we think of these anti-inflammatory drugs as very targeted, which they are, if you look at all their downstream effects, they become less targeted. You know, if you block TNF, we know IL-6 levels eventually go down, for example. And the history of combining biologics has not been a good one. So I'm not convinced that combinations is the way ahead. So that was a bit of a negative slide, really. But those are the thoughts that go through my head when I think about the therapeutic ceiling. I show you this slide because this is an important slide to me. You might, it looks a bit curious in the context of this conversation, but I'm only focusing on rheumatoid in this talk because that's a disease I really deal with. This is autologous stem cell transplantation. This is a slide that my friend Thomas Dorner gave me a couple of years back. And what I think is really important here is you've got 5 inflammatory immune diseases: systemic sclerosis, multiple sclerosis, lupus, JIA, and RA. And this is showing progression-free survival after 5 years. Look at rheumatoid. It's not the same as the other diseases. It's way worse. So, and that's been my experience with a lot of therapies I've tested over the years, things like Campath. The rheumatoid behaves differently, and I use that as a prelude to my next slide, which is a hypothesis. So what you've got here, and this is just, I could have shown you many similar slides. These are 3 anti-TNF trials, infliximab, adalimumab, etanercept from the very early days. And what you'll see is what you're familiar with. They all give fairly similar outcomes. So 60% of patients get 20% better, 40% get 50% better, and 20% get 70% better. I could have shown you similar data for rituximab or tocilizumab, and that's what we call the therapeutic ceiling. It's really hard to do better than that. Just think about this for a moment. This is a slightly different slide, a different interpretation. So what if there is an inflammatory component of the disease? And so what I'm showing here is percent improvement. So the ACR20 people, only 20% of their disease is inflammatory. The ACR70 people, 70% of their disease is inflammatory. What if there's a component of the disease that we're not treating with our anti-inflammatory drugs? And right now I'm going to talk about the stromal component, because we've heard quite a lot about fibroblasts in the last few years, partly because of the work from QMUL, a lot of the work from Birmingham. And we are hearing the story that fibroblastic rheumatoid is more difficult to treat. But all I'm suggesting here is maybe an ACR20 responder only gets 20% better because 80% of their disease isn't inflammatory. We just don't have drugs that can treat that inflammatory component. And actually, we've got a lot of good drugs that can treat inflammation. So actually, Ian and I and a few friends are testing that right now in a trial, which I'm just going to show you a single slide of, which is this trial called Traffic. We're using a drug called saliciclib, which actually inhibits fibroblast proliferation. It inhibits rheumatoid synovial fibroblast proliferation. And the hypothesis we're testing here is that if we take patients who are on a biologic therapy, who started off in high disease activity and haven't got to remission, so they're kind of stuck at moderate disease activity. Maybe they're the ACR 50s that we just saw. Can we add on this saliciclib drug and get them into remission? If we can, then that will tell us that the fibroblast is that part of the ceiling, that actually we can't smash through the ceiling because the drugs we've got at the moment are not tackling the right cells. Actually, you'll hear this very soon. I can't tell you exactly when, but the data are now in, they're being analyzed. And I've been saying this for a few years, but now definitely I guarantee that at the next big meeting you should see some data from this trial. We're very excited about it because it is a novel concept, and there's Ian, Chris, and myself, and subsequently with Karim Raza, who developed and ran this trial. And so the ceiling may be the ceiling because there's just a part of the disease that we're not treating. But there could even be an immune component of the disease that we're not treating. And these are data that Ian knows very well because they're from his wonderful lab in Glasgow, and particular Mariola's data. And this is now tackling a different cell. This is the synovial macrophage. And if you look down here in the bottom left-hand corner, this is a flow cytometry plot of myeloid cells taken from the joint. On the left in healthy people, in the middle, people with active arthritis, either naive to treatment or resistant, and then on the right, people in remission. And what you'll see is in health, you've got these myeloid cells which have this marker called MERTK, and it's high. And they've also got this marker called CD206, which is high. So they're in the upper right quadrant. In active disease, the myeloid cells are in the lower left quadrant, so they look different. But in remission, most of the cells look a little bit like health. And this is quite exciting because actually what Mariola's work and Ian's work has shown is that if you have too few of these, what I call these MERTK high cells, you're likely to flare. If you stop the drugs, you're likely to flare. And this, remember, is in the synovial biopsy. So people who don't have enough of these cells in the synovial biopsy, if you stop the drugs, they flare. And you can even calculate a ratio of these top right cells and these bottom left cells and get a ratio which tells you whether or not you can stop your drugs. And it's a nice biomarker. Of course, you've got to have the biopsy, so it's not brilliant from that perspective. But if you look at these cells in detail, these bad guys in the bottom left, they produce a lot of pro-inflammatory cytokines and so-called alarmins, and they actually make the synovial fibroblasts angry. So it goes back to the fibroblasts in my last talk, whereas these guys up in the top right, they produce what we call resolvins. They produce chemicals that resolve inflammation and actually cause the fibroblasts to repair. So I find this really interesting because what it says to me is we've spent many, many years focusing on inflammation. I've spent many, many years focusing on the adaptive immune response, lymphocytes. But actually, if the synovium itself isn't permissive, maybe we're never going to get long-term remission. So part of the ceiling may be that there are these fibroblasts and these myeloid cells, neither of which we're targeting at the moment, which actually hold the secret that we need to be doing better and looking beyond the traditional targets that we've been long talking about. And so actually this MERTK molecule is known to be a homeostatic molecule. So there are cells in the synovium which actually are there to try and get the disease better, if you like. So I'm going to shift gears very slightly. This used to be a title of one of my talks, From Rehabilitation to Remission in 3 Decades, and maybe I'm going to push back just a little bit on Janet. So this is when I started as a rheumatologist back in about 1990, when remission was very rare, disease was very bad. People came to my clinic in wheelchairs, they didn't work. Horrible disease. It's partly why I became a rheumatologist, because I wanted to find new treatments. Now, well, things are different. And as Janet has said, it's not just because we've got better treatments, it's because the way we use them has improved. And I actually think early treatment is possibly the really big change. We can rapidly reverse inflammation, prevent damage. And actually, our early arthritis clinic, about half of our patients achieve remission on methotrexate alone. But what I find really exciting is that half of these patients, if you stop their treatment, and actually the patients really would like to stop their treatment if it was safe, we get remission lasting at least 6 months. And if you put this into a concept of autoimmunity, we've always thought that diseases like rheumatoid were not reversible, that once you got diabetes, once you got lupus, once you got thyroid autoimmunity, it's a one-way street, and you just have to treat the symptoms, you prevent the damage, and that's all you can do. And that's been our strategy. That's treat to target, really. You've got to suppress what's there. But if you take the healthy immune system as a balance between aggression and regulation, and in autoimmunity, the aggression gets the upper hand, and we now talk of dysregulated autoreactivity. We know that we all have autoreactive T cells and B cells, but normally they're in balance. In autoimmunity, that balance is dysregulated. We then give drugs like methotrexate, other drugs to rebalance the system. And that's how we get our patients into remission. But what I'm now telling you is you can stop therapy in a proportion of those patients and they don't flare straight away. So what that tells me, or what it might tell me, is that those immune regulatory mechanisms, whatever they are, partly in the synovium, partly in the blood, are trying to self-regulate. They're trying to keep that disease under control. And it's what I call retuning. I think the immune system is attempting to retune itself back to homeostasis and back to health. And so just to think about that, drug-free remission is achievable in probably 20% of early RA patients, no more than that, and we don't know which ones they are again. It's probably not forever. It's probably not tolerant. They will probably flare sooner rather than later. We don't know exactly when. So it might be immune tolerance in a few patients, but we don't know that. We don't have the biomarkers to tell us. The other thing to say is in the old days when we didn't have early arthritis patients, actually some patients seemed to remit spontaneously anyway. By the time they came to the clinic 9 months late, their disease was actually quite settled. They were the rare patients, but I think that might have been telling us the same thing, that disease sometimes tries to reset itself or retune itself. And as Janet suggested in her persistence, patients have flares, but actually sometimes those flares resolve without any intervention, again, which tells me that the disease is trying its best to keep the disease under control. So I think this isn't solely an early disease phenomenon, but I guess it's probably easier in early disease. And actually that 50%, I should say, it's not the same once a patient's on a biologic. The chance of drug-free remission becomes much less once the patient is on a biologic drug for whatever reason. But I think autoimmunity is possibly reversible. And if we had the right drugs and we knew how to use them, we could cure and we could definitely get long-term remissions. So let's think about retune. I've mentioned it in that last slide. This is type 1 diabetes. And this is a study of a drug called teplizumab. It's over there and over on the right. And these are patients who haven't quite got diabetes yet. They've got a couple of autoantibodies and they're dysglycemic. They're stage 2. It's a bit like us talking about seropositive arthralgia, I guess. They're on the way. But the difference in diabetes is they all progress. It's not like rheumatoid where you can't tell. These patients are all going to get diabetes. But you can see there's 2 lines here. These are the placebo people, and these are the patients who've got anti-CD3, which is an anti-T cell drug. What you might be surprised about is that they only got treatment for 14 days. And this is showing you data for 6 years. And some of these patients in this study had been 8 years out. And at 6 years, there's still a difference. Now, we don't know, again, whether all of these patients will eventually get diabetes, but their time to development is doubled if they do get diabetes, and the hazard ratio is halved. So that 2 weeks of treatment has made a huge difference to the likelihood of these people getting diabetes and presumably their immune system. So again, for me, this is a retuned immune system. Something has changed fundamentally just after 2 weeks of treatment. So this brings me on to reset. We're hearing a lot about reset these days. These are the data from Erlangen that were published in the New England Journal last year. My thoughts about it are in a commentary in the same edition. And I'm sure you all know these data. There were 8 patients with lupus, 3 patients with inflammatory myositis, and 4 patients with systemic sclerosis who got a single infusion of autologous CAR T cells following lymphoid depletion. And they did, on the whole, very well. These patients at 6 months, certainly the lupus patients, were off all treatment, including steroids. Their autoantibodies had pretty much disappeared. And for all intents and purposes, they looked externally normal. Similar data in the myositis, perhaps not quite as good, and it's definitely one of these patients flared subsequently. And the systemic sclerosis patients also on a trajectory of improvement. So this is being called reset. Of course, it's a small number of patients. We don't know how they are going to do in the long term. If you look at the paper, the reason it's called reset is if you look at their immune system, what happens is these CAR T cells ablate probably all of their B cells. And then at about 6 months, the B cells start to come back again. And their immune system starts to look a little bit, I presume, like a newborn baby's immune system, with naive B cells appearing and slowly maturing. Why does it work? Or why do we get those data? Well, the first thing to say is that these CAR T cells recognize CD19, and the expression of CD19 is a little bit broader than CD20. Critically, it targets plasmablasts, which is perhaps why the autoantibodies disappear. The other reason it's better is because cells are better at killing than antibodies. These cells will get into the tissues, they'll find their way around the body, and they probably are depleting. That myositis patient that I mentioned that eventually relapsed then got another CAR T cell against this antigen called BCMA, which is actually on the long-lived plasma cells. So these people have had their entire B cell lineage wiped out, perhaps apart from some very, very, very early B cells. And apparently after that CAR T, this patient went into remission again. But again, that's relatively short-term data. And if you wipe out the long-lived plasma cells, presumably you are going to lose a lot of your protective immunity. So this is probably why it works. So you may have seen these data. In the top left here, we're looking at B cells in the CD19, CD20, and plasma cells at baseline after CAR T cells, and actually in patients after rituximab. And what you can see after CAR T cells, these are lymph nodes. There are actually probably some of your biopsies, I think. There are no B cells or plasma cells to be seen after CAR T, whereas after rituximab, there's quite a lot. Actually, it is lymph node data, actually, I do recall. After rituximab, there's a lot of cells left. And here are data, which is kind of interesting, looking at follicular dendritic cells, which aren't targeted by the CAR, T follicular helper cells, which aren't targeted, and basic proliferation. And again, after the CAR T, you even lose the FDC networks and the T follicular helper cells. So the whole system does seem to be disappearing after these CAR T, but not after rituximab. So the difference is just probably deeper depletion. Now, what that means, it's being called reset. Is it safe? Is it going to be safe in the long term? It's an expensive treatment. It's a very involved treatment. These patients stay in hospital for 3 weeks at the moment to get their treatment and to recover from their treatment. As you've heard, there's other ways of perhaps depleting not quite as deeply with these bispecific T-cell engagers. The story's not going to go away for a while, but it is early days. As you've really probably just realized, I like to talk about immune retune rather than immune reset. So I think for reset, you probably do require deep depletion. It's definitely not antigen specific. You're targeting all the B cells pretty much. So there may be consequences, although these patients surprisingly still make a vaccine response. It's probably because the CD19 CARs don't kill the long-lived plasma cells. So they are still there. But the sorts of treatments that bring about immune reset are stem cell transplantation, CAR T, possibly the BiTEs, the bispecific T-cell engagers, although I suspect patients will relapse sooner after those. Whereas immune retune, I think of as more subtle, non-depleting therapies. And incidentally, that anti-CD3 in diabetes, it didn't kill any cells. None of those T cells were killed. Doesn't need to be antigen specific. Anti-CD3 is a good example. Maybe the checkpoint agonists, which I think Janet briefly mentioned, may have that potential, but we don't know yet. But they're not anti-inflammatory in the conventional sense. They are targeting T cells. So when do we target our therapies? And again, you've heard a little bit about this already. I think the big change over the last 30 years has been the fact that we treat our patients these days probably within 3 to 6 weeks of symptom onset in a good early arthritis clinic. Patients are being referred early, they're being treated early. And going back to my fibroblast story, I actually believe the fibroblasts are possibly not engaged at those very early points of disease in many patients. And it might be why the patients do so well, because we've got really good drugs like methotrexate and anti-TNF and tocilizumab and abatacept. And if there's no fibroblastic disease, theoretically, I guess any of those could actually put our patients into remission. And they do in early disease. But what about pre-disease? So you're familiar with this story that tolerance is broken up to 15 years before the disease appears. So you lose you gain your autoantibodies at that stage. Then if you look closely in biomarkers, you can see the immune response maturing maybe 5 years before the disease. The patient feels fine, but if you look at stored blood samples, the CRP's going up, there's cytokines, there's chemokines, something's going on. You then end up with subclinical inflammation and arthralgia, but no active inflammation. And finally, you get synovitis and you get what we call arthritis and clinical inflammation. But, we've been talking about this for many years now. Can you treat before the patient actually gets a disease? The main problem is the one I've hinted at earlier on, is that in diabetes, for example, we know that all patients around about here are going to get diabetes. So ethically, for all sorts of reasons, patients would like treatment at that stage to stop them getting the disease. With rheumatoid, it's not quite the same. We still haven't got the absolute biomarker. So even here, maybe even here, 70 to 80% of patients may progress, but there's still a very small proportion that don't seem to, at least not in the short term. So we have to be careful. But nonetheless, as you know, there have been trials. This is the EPIPRA trial. This was Andy Cope's trial. And the primary data, so these patients got abatacept, the blue line, for 12 months, and the control patients in red. And at 12 months, the abatacept was stopped. So certainly at the end of treatment, there was a difference between the two groups. Even a year later there was, but you can see that as soon as the abatacept was stopped, that the lines tended to come together, suggesting that abatacept had perhaps slowed disease rather than prevented it. But we don't know. There could still be a difference. What's really important, though, is these words below. I haven't got a slide for this because it's not been published yet, so I didn't want to show the data. But patients that had multiple autoantibodies, they had ACPAs, they had anti-carbamylated antibodies, they had anti-acetylated antibodies, they had IgG, ACPA, IgA, anti-CCP. Really interestingly, those patients, this line was more or less straight. So it went on. They didn't flare after treatment. So it almost feels like the more active the immune system at the time of treatment, the better the outcome. And what's interesting, actually, in those diabetes studies, like the anti-CD3, the same story is there. The patients with diabetes, where it's possible to show a really activated immune system by whatever means, they actually do even better with the anti-CD3. They're the ones that don't relapse. So there's something about treating an active immune system with these immune retune therapies. Perhaps it's not surprising if your immune system isn't that active, the immune retune drugs don't work so well. So watch this space. I mean, actually, Andy's data with the biomarkers is a really good precision medicine study, because those would be the patients you'd want to give this sort of treatment to, because they do very well for at least 2 years, and actually longer than that. I think Andy's now got data up to 5 years. So, as I say, my slide on biosimilars and generics is more for discussion, because I don't really have any data to show you. Again, as hinted at earlier, should methotrexate be our first drug? We've got biosimilar biologics, but soon we're going to have generic JAK inhibitors. There's going to be a generic tofacitinib before too long. Is this going to change the treatment paradigm? Maybe intentionally or unintentionally, will people buy these cheaper JAKs? Will they stall the development of new drugs for RA? Will using JAKs or anti-TNFs earlier break the ceiling, or will they just confirm the ceiling is there? Will we still have patients who don't respond even when we give these treatments at the beginning? And actually, will placebo-controlled trials remain ethical? If you've got these good, cheap drugs, can we really withhold treatment for 12 weeks even in patients where there are good, cheap treatments out there? So we might discuss some of that if there's a bit of time. So I think that's my final slide. So that I would argue we haven't smashed the ceiling yet. This will take new approaches, possibly novel cell targets rather than new signaling pathways or cytokines. I think earlier treatment will lead to incremental improvements now by going into perhaps into pre-disease. And earlier use of targeted therapies may improve outcomes or may simply remind us that the ceiling exists. I think immune reset is potentially promising, but it's a big hammer. It's a really big hammer. So watch that space. I think if we can get immune retune right, that would be more acceptable across the disease spectrum. So that's my last slide. Thank you.
Fantastic, John. Thank you very much indeed. We're got a couple of minutes for questions, so I'm going to ask for really sharp, short answers from my colleagues. Keen to take a couple of the questions. We've answered some online, but Dr. Hamdi Ramadan's asking about long-term safety if we use early biologic treatments. Janet, a short synthesis of
right.
there.
Safer than if you fail a bunch of drugs. Order of therapy matters. When you're naive, there's a meta-analysis showing early RA. Advanced therapies are equally safe on serious infection rates as methotrexate monotherapy.
Beautiful, Janet. And Ursula, nice to see you or hear from you or read of you, Ursula. Thanks for your several questions, actually. John, Ursula's asking, interesting question. If we treat before disease, how would that actually function in the marketplace? What's the value of prevention? I mean, treat blood pressure, prevent strokes. Yeah.
I think there's two elements there. First of all, of course, there's a regulatory element, and the regulators want to know. One of the difficulties of treating pre-disease is how do you know whether it's worked or not? It's a bit like the diabetes. Have you really prevented disease, or was the patient not going to get disease in the first place? So we need the biomarkers to tell us that the arthritis has switched off, and I think the regulators will demand that. The second question is, how do you find the patients? If they've already got arthralgia, you will find them because they will refer themselves to doctors. But the earlier ones, of course, would require screening. In America, they have these what they call them, health shows or health fairs, where there might be a van saying, we can check your autoantibodies for you. So it's possible to be detected, but there's that big ethical question. Are you really going to get rheumatoid, or are you just one of those people, lucky or unlucky, who have autoantibodies who won't? So great question, very complicated to answer. There's no robust answer at the moment.
But we'll get there. And I think that's the idea of the community of rheumatology working globally. We really are going to have to work together here. I appreciate there are still individual groups and individual idiosyncratic thoughts, but as a community, we can take on these really big challenges, which is super exciting. The last question we're going to have time for is from Edgar Stemler. Edgar, thank you. When I first read your question, I thought it was a statement of fact. I completely agree with you. And Edgar's question concerns the issue of, should we be direct? I'm paraphrasing a little. Should we be directly thinking about modifying neural pathways? Well, honestly, folks, when you think of fatigue, when you think of behavioral changes, when you think of brain fog, cognitive dysfunction, hides a multitude of sins, that beautiful medical phrase, cognitive dysfunction. When you think of all of the challenges that our patients still face after they've apparently undergone successful immune modifying therapy, I have to say that we've got a long way to go. And I completely concur, Edgar, that the way into that is going to be by understanding the pathways. And we've got other questions coming in. I'm so sorry, we're not going to have time to deal with them. I'm devastated by that, but we'll try and type in. Maybe John, you could type in an answer to the issue about teplizumab, while I just make one or two very quick closing remarks. Well, first of all, thank you so much for joining us. It's been an absolute blast to have you with us, and I hope, whether it's the morning, afternoon, or evening, that you have enjoyed it. Let us know what you found valuable. A little feedback. There's a little evaluation form at the end. It'll take you 30 milliseconds. Fill it up, let us know, and we'll use that to populate future webinars. Because frankly, the only reason we do this is because we want people with immune diseases to receive better standard of care. And by sharing and discussing and sharing what we know, but also I think what you'll have heard today is sharing what we don't know. Is every bit as important. The live stream version is going to be available on the IMID Forum YouTube channel, imidforum.com, all one word, IMID Forum. It's a treasure trove. You've got reviews of papers, podcasts, previous webinars. It's free. Imagine a Scottish person saying that to you. How often does that happen to you in your life? It's a cracking resource. Thank you so much to Lily, who provided the support. It was an independent educational grant. I think you'll see from the content and nature of the discussion that we really appreciate what they gave us, but we also didn't sense any compulsion from the company as to how and what and where we were going to take our discussions. The forum, here's the QR code. We'll just leave it on at the end here for you to sign up. It's a lot of fun. It's been something we've been working on for quite some number of years now. It leaves me only to thank two of the incredible colleagues who have made the forum work. John Isaacs, Janet Pope, you've shared your knowledge, you've shared your expertise, you've shared your insights, and you've done so in your usual charming and engaging way. Thank you both for making the webinar such an enjoyable place for us to be. And with that, ladies and gentlemen, I'm going to bring proceedings to a close. It's been a joy to have you with us, and I wish you well wherever you are, whenever you're listening to this. And as I say, this is about the patients. Let's use our newfound knowledge and also those questions that remain. Let's use that to improve the lives of people with immune disease. Thanks ever so much. Goodbye.